Welcome. We're going to go ahead and get started. I'm Deb Burnett. I'm director of the Lucent Primary Care Leadership Training Program, and we are delighted to have you here and to have our speakers here, our panel of speakers, who I will introduce to you in just a moment. And I want to give you an update and reminder about Lucent. We have been recruiting fellow and resident participants for the coming year. We're creating primary care tracks within our medicine, peds, med-peds, and family medicine training programs. We have residents who've applied. We have a fellow who will be a full-time Lucent fellow next year, and we are still accepting faculty applications for faculty who would like to be Lucent scholars in the coming year. In the coming year, we will have Lucent symposia twice a month, which will be primarily skill-based sessions on primary care leadership topics and skills. We will still have quarterly speakers, including external speakers. So we have a couple of more of these monthly sessions this year, and then by next year we'll be moving into twice-a-month sessions, especially focused on the Lucent scholars who are residents and faculty, but also quarterly sessions and speakers that are open to everyone. The remaining two speakers for this year, next month on April 21st, we'll have Elizabeth Salisbury Afshar. She is a family medicine physician, and she's the medical director at Heartland Health Outreach, and she will be speaking on the opioid epidemic, what primary care providers need to know. Very important topic. So come to that, and then in May, we will have Denise Rogers, who's a family medicine physician, and she's the vice chancellor at Rutgers, and she'll be speaking about leadership roles for primary leadership roles and careers for primary care doctors. So today I want to tell you about our speaker panel and also introduce our moderator for the panel. The first speaker on the panel is Joel Jackson, sitting just to my left. And Joel is the manager of training and education in our UCM, Department of Diversity and Inclusion and Equity. Joel is from St. Louis, and he was the first male to major in women's studies at WashU in St. Louis. Thank you. Prior to joining us here, he was the program manager for the Center for Diversity and Cultural Competence at Barnes-Jewish and WashU in St. Louis. So we are delighted to have him here. He's been with us for a couple of years, and he's a fabulous trainer and colleague. Sitting next to Joel is Jim Pickett. Jim is the Director of Prevention Advocacy and Gay Men's Health at the AIDS Foundation of Chicago, where he's worked for the past 11 years. He's a premier advocate for gay men, for gay health. He co-founded and leads the International Rectal Microbicide Advocates, or IRMA, group, and also is one of the leaders of the Chicago PrEP working group. I saw the Prep for Love ad on the bus yesterday in Chicago, so thank you for working on that. He was inducted to Chicago's Gay and Lesbian Hall of Fame by Richard Daley. That's the old Richard Daley, right? Senior Richard Daley. And Jim has been... Oh, the junior one, okay. Gotcha. Good, okay. And Jim has been living successfully with HIV for over 20 years, so thank you very much for joining us and for your work. Mary Bowman is on the end of the table, and Mary is an advanced practice nurse at Chicago Women's Health Center, a nurse-managed feminist health collective founded in 1975, where they provide primary care and gynecologic care to cis women and trans-identified people. Mary is also a nursing instructor at DePaul for accelerated nursing students, RN students, and a reproductive justice activist. Thank you also for joining us. And our moderator today is John Schneider, whom many of you know. Dr. Schneider is an associate professor in our section of infectious disease and also with an appointment in public health sciences here at the University of Chicago. John directs the University of Chicago Center for HIV Elimination, and he specializes in HIV prevention and has a specific interest in providing high-quality care to younger black men who have sex with men and to transgender women. He works also in both a federally qualified health center on our south side and has worked and studied in India, where he studied how social networks can be leveraged to improve health of at-risk populations in resource-constrained settings. So thank you for your work, John, and also for leading us today in a discussion with our panelists.
Thank you. All that network analysis couldn't help with the technology. Well, thanks everyone for coming. It's a privilege to be here, and thanks to the audience. So I guess to kind of just sort of liven it up a bit, tell me a little bit about, we'll kind of go down the panel, like what is a typical day in the life with respect to LGBTQ health for each of you? Yeah, that one, that's it.
Is that on? I don't think so. Is it on?
Yep.
Okay. So I'm Mary. I work at Chicago Women's Health Center. We have a very unique care model. So I spend an hour with each of my clients. They're with me from start to finish, so I take them back, I vital them. I talk into the microphone a little further away. I vital them, I do their history, I do their exam, I diagnose and treat them, and then I take them back up to the front and they pay me. So we don't have a lot of administrative staff at my health center. We don't have a lot of support staff at my health center. We have a lot of health educators. But it's me and one other nurse practitioner and a number of health educators running things. What that means for LGBTQ care, well, first of all, I mean, we have some trans men who identify as gay who we see, but we don't see cis men. So we see some of the G in the LGBTQ, but mostly the Q and the T.
Can you explain, in case everybody doesn't know, what the language is about trans men and cis?
Oh, sure. So a cisgender person is someone whose gender identity agrees with the sex that they were assigned at birth. And trans people are everybody else. It's a lot of different gender identities are encapsulated in the trans identity, so that's a talk for another day. We were founded in 1975, and so we have been a gynecology practice for a very long time, and have recently evolved to do more primary care and provision of testosterone to trans men kind of evolved out of our existing patient population. They were asking for us to provide that service, and through some kind of political discussions in our collective over the years, we have since evolved to provide hormones to trans women and everybody in between. So a day in the life is I have a lot of direct contact with my clients. Nobody does my follow-up for me. I do my follow-up for myself. They can contact me pretty directly. We have an informed consent model for our hormones, so they don't really have to jump through any hoops or prove their identities to us in order to start hormones. So probably about a third of my practice is hormone management for trans people. And the rest of it is just kind of filling in the gaps. We have a sliding scale that is not income dependent, so people can qualify for our sliding scale without showing proof of income. So we see a lot of undocumented people, a lot of sex workers, a lot of folks who make just too much money to qualify for public aid. We also see a lot of people who've been traumatized in other medical settings because our model of care is feminist and trauma-informed. What that means for the queer folks that we see, I mean, we've always seen queer folks. We were one of the first places in the city to offer an alternative insemination program for single and lesbian women. And so it's just kind of built into our feminist practice. We respect people's bodies as their own, and we don't make any assumptions, and we ask them to self-identify, and we respect what they say. So.
Sounds very good. So my name is Jim Pickett. I'm at the AIDS Foundation of Chicago, where, as they said, I've been for 11 years. I started off as Director of Public Policy, and I soon segued. I enjoyed it to a degree, but I'm not a Medicaid wonk, and I liked being on the Hill, but I didn't like, well, there's a lot about that I didn't like being on the Hill. So I segued into more of prevention advocacy, and for a long time we founded IRMA, the International Rectal Microbicide Advocates. If you haven't heard the word microbicide, It's a new form. It's a type of HIV prevention technology that's in development where it's applied rectally or vaginally. It could be a gel, a lube, a douche, a ring, a film, fiber, all kinds of different things that would provide protection whether you had condoms or not. So we got very excited about that. Much of my work has been about advocating for new technologies, so connecting communities to scientists, scientists to communities, to make sure that communities were really leading the research agenda. We shouldn't be spending money and going down roads that people aren't interested in. If we create something that works really well, but everyone doesn't like it, it's not going to matter. It's going to sit on the shelf and it'll never get where it needs to go. So did that for quite some time, and then in 2012, and that included all technologies. So we were IRMA. We definitely focused on rectums because everyone in the world has a rectum, and lots of people have anal sex. It's not just a gay thing. It's not just a trans thing. It's a human thing, and we need to protect both vaginas and rectums. And previous to us forming IRMA, there was a very robust vaginal microbicide advocacy movement. Women really created microbicides. It was female advocates who said, hey, we need something that we control for prevention, like we have things we control for contraception. And so then, because of political things and the ick factor and homophobia and denial that we exist, or that denial that women have anal sex, rectal microbicides just weren't on the agenda. They were hidden. During the Bush administration, scientists had to scrub their abstracts. You wouldn't be able to find any information, even if they were doing work, because rectums and anuses and gay men and trans were just removed from paper. That's the only way they were getting it funded, and that was the only way they kept their funding going, so a nosy legislator doesn't go in and look on the database and find out, oh, the National Institutes of Health are funding these anal sex studies. So anyhow, that's why we formed IRMA. But it was always inclusive, always female-friendly, and always looked at a variety of technologies. Well, in 2012, the Food and Drug Administration approved our very first new prevention technologies. So PrEP, or pre-exposure prophylaxis. It's a generic term. A microbicide is PrEP as well. PrEP is the first thing we have. It won't be the last, or the version of PrEP that we have is the first that we have. It won't be the last. It's basically taking Truvada every day. Truvada is an antiretroviral drug, two drugs in one pill. Can be taken for treatment, can be taken for post-exposure prophylaxis. And we now know if it's taken every day by individuals who are vulnerable to HIV, it's excellent at protecting them from HIV. Up to 99% effective. We have just heard of one breakthrough case. So out of tens and tens of thousands of people who have taken PrEP, there has been one case where apparently this person was adherent, and they came across a very rare multi-drug resistant strain of HIV that had resistance to both drugs and Truvada, and infection happened. So all that to say, I was advocating for a long time for things that were hypothetical, things at the end of a tunnel. We had to encourage people, communities especially, who are thinking about HIV on a day-to-day basis. Why should we be excited about something we've never heard of? Microbicides sounds like something you kill weeds in your grass with. We need to worry about today, and we can't think about tomorrow. Well, when tomorrow came and we got PrEP, a lot of my work turned into implementation work, implementation advocacy, and making that work. So once we knew it worked and it was approved, that's just the very first mountain we all had to climb collectively. The second mountain and ongoing is figuring out how to get this to people who most need it, how to wrap around the correct services, how to message it. So since then, I've been doing a lot of work with that. A lot of that has been in close collaboration with John and other folks here at UC. It's been lovely. And we formed the Chicago PrEP Working Group, which is a collective of researchers, clinicians, advocates, educators around the city, kind of coming together to figure out how to improve awareness and access. And one of the things we did was launch a campaign, and I did bring some slides. If we have time, we'll show them later. It's like baby pictures. And so, yeah, I don't know if that even tells you at all what my day in my life is, because if I told you it's sitting at a computer a lot and talking a lot, and that's about all I do. But it's really trying to, affect change and trying to make the best out of this. And even as we're making the best out of PrEP, continue to keep our eyes on the pipeline where all these new things are coming and continue to foster support for funding. There is this sense that, oh, we have PrEP now we don't need those other things. And we want to have a wide array of options. There's a wide array of contraceptive options. They're not always available to people, but we do have them, they exist. So we want to have a wide array of things that are available and exist for people to choose for their HIV prevention needs. And that's my blurb.
Thanks, Jim.
Sounds like you're doing a great job. A lot of things. So I'm Joel Jackson. I am Manager of Education and Training here at University of Chicago Medicine for our Diversity, Inclusion, and Equity Department. So my role here is more so focused on the team, focused on the staff and employees here at the organization, and trying to help create a more welcoming and inclusive environment for disadvantaged populations. So that's not exclusively just the LGBT community. At the same time, the LGBT community is included in that. So a few things that we do specifically to help create a more welcoming environment for LGBTQ persons. We do participate as a hospital in the Human Rights Campaign Healthcare Equality Index. And in this past year, I'm happy to say we recently gained our leader designation, largely in part due to the efforts of one of my colleagues sitting right over there, Lisa Sandos, who's also in my department. And I should say that, a year ago we only had 1 out of the total 4 points that we could have in order to be a leader. And, within 1 year to move from having only 1 point to having all the points needed to become a leader is actually a huge effort. It took a lot of work from everybody that on multiple levels, from leaders on the way down. So that's actually a very, very, very huge thing because the community pays attention to the Healthcare Equality Index and the organizations that participate in it. In addition to that, we also offer cultural competence training to staff. And as part of our cultural competence course, we do include content that focuses on the LGBTQ community. When you participate in cultural competence here, we don't focus on sort of the top 10 things to know about the lesbian, gay, bisexual, transgender community. Instead, we focus on skill building. So what are the skills that our team members need to have in order to operate in a cross-cultural environment like our own? And so it's after individuals would graduate sort of from our course that they can also participate in ongoing engagement with cultural competence. And then we offer a more specific training called Caring Health Services for LGBT Patients. And in that training, it's a 3-hour training where we really focus on the basics, just understanding terminology related to serving this community, and also learning the disparities that are impacting this population, and the best practices for how to better serve members of this population, especially if you are in a clinical role here at the hospital. In addition to that, I also work somewhat helping at the Village, which is it's sort of like a drop-in center for youth who are part of the LGBT community that's also a part of UCM, helping with some of the programming and things like that. And I'm also a member of the community, so I participate in some of the programming myself. I actually am on PrEP myself, so I could speak to that if you wanted to hear from somebody who's actually taking PrEP. And I also participate in what's called the sort of ball culture, house culture. If you've never heard of it before, it's not like Cinderella when you think about a ball. There is, well, I guess, it depends on how you think about it. But there is a documentary called Paris is Burning, 3 words. And it is on Netflix if you wanted to sort of get more of a historical perspective of that community as well. But that takes place sort of back in the 80s. In addition to that, prior to doing more work related to cultural competence in healthcare, I actually worked for 10 years for an organization called Project ARC in St. Louis, and ARC stands for AIDS Resources and Knowledge. It's affiliated with the pediatrics department through the School of Medicine. But working there for 10 years, I actually worked in prevention and care. So I worked with individuals who are infected as well as impacted, meaning they may have an immediate family member who's infected or at risk for contracting HIV themselves, running support groups and such like that. And we actually started a drop-in center for youth there where young people could come and access free prevention services, testing, and connected to care and treatment as well. So I can't really tell you what my day-to-day work is like when it comes to serving the LGBT population, because my work is sort of to work from margin to center, and so I guess every day I am working for that community just by the fact that I'm working to sort of help bridge the gap and to create a more inclusive environment for them. So, for us, I should say.
Great. Mary, I had some questions for you. Are you okay?
Can we get another bottle of water, please?
Do you want to?
No, I'll be fine.
Okay. So I was intrigued. So spending an hour with a client and
Jealous?
not having to deal with administrative issues just sounds like a dream job. So tell us a little more about how you were able to kind of set yourself up that way.
Yeah, it is a dream job. That has always been at the center of our model. You know, part of the reason why we added primary care wasn't just because of the needs of the community, because it was so inaccessible for people who are uninsured or low income, but because the changing guidelines for gynecology screenings really kind of took a bite out of our practice and how frequently we would be seeing people. So, oh wow, thank you. What service? So it's just always been that way. We evolved out of, you know, we were founded in the 70s as a part of the feminist health movement, which was basically peer education. Women didn't know their own anatomy, didn't know their own physiology, and so it was a lot of women educating women about how things worked and what was normal and what wasn't. And so when some of the ladies from the Jane Collective, I don't know if you all know Jane, but it was an underground abortion service that operated pre-Roe. And so some of the people from Jane and some other folks got together and founded the health center after Roe happened, and they were acquitted. They were about to go to jail. So it's always been, I mean, right now, patient-centered care is pretty catchy from ACA, but I think that we're the true embodiment of that. That's always been how we've operated. We've never been profit-driven. We don't have any federal funding, so we don't have any state funding either. We don't have any funding, but we're not beholden to anybody else's interests. We only just started taking insurance, which took a little bit of the dream out of the dream job. But you want to be accessible to more people. Now that ACA is making insurance slightly more accessible to people, we want our patients to be able to use their insurance. So we're trying to move in that direction. But I mean, we don't have long appointments because we get really paid. You know, like that's not why we chose that model of care. It's because that's the only way you can actually heal people is by listening to them. And half the time, people tell me everything that's wrong with them because they have enough time to talk. So, and they just feel it's a qualitatively different kind of experience to come into an office and have somebody listen to you, instead of having somebody, 5 people shuffle you through and then have a provider come in and do the thing that they get paid the most for and leave. So, and then have 5 other people call you later. So it's the only way I would provide care. I really hope to make our model replicable so that other places can do the things that we have done. I think that part of the way that we can do it is nurses are less expensive than MDs. And so having a nurse-managed health center is less expensive to run. Also, our medical director is a volunteer. We grew out of being an all-volunteer organization, so trying to replicate it is going to be a challenge. It's a uniquely Chicago thing. But yeah, we fight all the time to preserve those long appointments. It's not it's not cost effective, and but it's why people have been coming to us for 40 years.
Yeah, that's wonderful. Jim, in your opening comments, you said, we're kind of always looking for the next thing in HIV prevention, and you also described yourself as sort of an implementer. So you want to get these things out and people using them. How do you balance those two things? Because I would imagine that we have one bucket of money. I don't want to pit one thing against another, but we have one bucket of money. We have a lot of effective things. How do we balance that implementation with the next discovery for prevention?
Yeah, that's a great question, and that could be its own seminar. Well, I think we have to just recognize that while we do have a few interventions available for HIV prevention, it's just a few. Most of the things that we've been doing for a long time haven't borne out to be very effective. Condoms are only effective if they're used each and every time correctly, consistently. And if you don't, they lose efficacy very quickly. So, we're very excited that we have this daily pill. But for a lot of people, this isn't an acceptable alternative. Some people do get side effects. They may not enjoy those side effects. Some people don't want to take a pill every day. Some people want things that are more longer acting or less user dependent, so excited about something like a vaginal ring. You pop that baby in there for a month, you don't have to think about it. So we really want to have a method mix. And so we have to continue to say, we know that we've always said there's one size doesn't fit all and there's no silver bullet, but yet our kind of human need is to find that thing and then say we're kind of done. On the other side of it, though, the other side of that discussion is where I get frustrated is people who are saying, oh, it's tricky to do this daily pill, and it's an ARV drug, and it's expensive, and da-da-da-da. So let's just chill, and we'll wait till the long-term injectables come. And that drives me crazy because there's this magical thinking that, oh, we'll get people to come in 6 times a year for a shot that lasts 2 months, and that'll be easy because that's not a daily dosing strategy. Well, there's all kinds of trouble with a 6 visits a year model. There's concerns about long-term injectables, the tail, how long that drug actually stays in your body. So nothing is sort of perfect. So I think there's that other side of people looking to the next best thing because we realize, oh, well, Truvada is not so great, it has these limitations, but the next thing will fix it for us. And so it is kind of balancing that, and they're both really important. We have to do our level best to implement Truvada as PrEP. I think we're going to have it on its own in terms of new technologies for probably a decade. Everything else is a ways away. We have a lot of research to do, and it has to get approved, it has to get into the market. I don't think we're going to have anything really soon in this country. We may have vaginal rings sooner in sub-Saharan Africa. Folks have heard there was some great news at CROI, the Conference on Retrovirus and Opportunistic Infections that happened a couple weeks ago. John was there, maybe some of you were there, I was there. And a dapivirine ring, so a ring that has a drug called dapivirine in it that was used for a month at a time, showed efficacy. It ranged, it was based on adherence really, but from about 30% to up to 60%. So 30% doesn't sound so exciting. Maybe not in our epidemic here for women. Women here are not generalized as high risk, but in sub-Saharan Africa, everyone is vulnerable to HIV if you're sexually active, and the rates of HIV are so high that even something with sort of very modest efficacy could save hundreds of thousands of lives, save hundreds of thousands of infections. So that's moving forward. There's now an open label study. We're going to understand more about how those rings work. And I'm super excited about that. That'll add to the method mix. And I think we have to continue to keep our eyes on both. And it's tough. There's always fights about scarcity and priorities. We can't fall into that, I think. We have to, again, do our level best with what we have. And we have to continue to say we need options for people. People's sex lives change over time. Their needs for protection change over time. Their ability to use different modalities change over time, maybe over years, over months. So we really need to give them options. So when we say the best intervention that you use is the best prevention for you is the one that you use consistently and correctly, well, we need to give them options. We need to have a buffet. For the longest time, our buffet was, potatoes. It was just potatoes. That's potatoes equal condoms, in case you didn't catch my. So we were just telling people, enjoy those potatoes. That was it. And we had mashed potatoes and garlic potatoes and whipped and gratin. Thank you. You know where I'm going. But they were still flipping potatoes. And some people got sick of the potatoes. And so we need to have multiple things on that buffet so they can find protection that fits into their life. And I think importantly, allows them to enjoy sex and have pleasure and intimacy and get their heads out of this sort of, we focus on risk and vulnerability and danger. And we've seen a lovely thing with Truvada occur, that people are able to have a peace of mind that they never had before. People report consistently peace of mind. And so you're kind of not worried about HIV every second, especially when you're having sex. It's a real bummer to live your whole life fearful when you are in an intimate moment. And to be able to take that away is a huge blessing. And I think if we have more options for people, so you know what, I have my prevention down, I have my ring in, and I don't need to negotiate this with anybody. My partner is not going to know that I have it in, and I have protection. And that ring in the future, I'm already jumping to the future, but that ring is going to be multi-purpose, and it's going to have other STD prevention in that ring that is released over time, and it's going to have a contraceptive, if that's what you want. Or it will have a ring that's non-contraceptive, but HIV prevention, so you can have children and not worry about getting something extra that you didn't bargain for. So I'm not even sure if I answered your question, John, but I got on a roll. I think I'm going to close it here, and we'll let you go to the next question.
It's always lovely to hear you talk. Joel, I was struck by, so you have this role here where help the staff learn more about diverse populations. I think you used the word disadvantaged populations, and you said LGBTQ was a disadvantage. How do you, what do you think about the intersection between some of those different quote disadvantaged groups? So, for example, African American LGBT, and how does the training change? Is there a change in training? I mean, are there ways that you think about it or are thinking about it?
Good question. So, studies actually show that the more, I guess, disadvantaged identities that an individual has, then the more disparities that person could perhaps experience. So, of course, no one exists just as one aspect of their identity. We all exist as intersections of multiple identities all at the same time. With that being stated, that's sort of why it's important to think about how to create interventions that are serving people from margin to center, because the idea is if we can meet the needs of the most marginalized, then everybody's needs will be met, right? You know, just thinking about, for example, the American with Disabilities Act, you know, the fact that, you know, all of us cannot move upstairs, but all of us can move up ramps, right? So if we put ramps in, then everybody's needs will be met, right? And then when they put ramps on sidewalks, then there was a disparity that was occurring for individuals who were blind and used canes when walking because they needed that sort of trigger that they were getting ready to walk into the street. And so that's why now the ramps on the sidewalks have ridges or bumps in them, right? And so again, it's just thinking from margin to center, how to better serve our population from margin to center to make sure that everyone's needs are met. You know, so that means doing things like making sure that structurally we have policies that can meet the needs of everyone for accountability, right? So that we enumerate categories by stating that we will not discriminate against you because of your race or sex or gender, sexual orientation, and things like that. As it relates to training, Again, that's why it's important to try not to focus so much on the population itself in terms of these are the things that you should do when you're working with a LGBTQ person, right? Because that just sort of feeds stereotypes. And if we're going to be patient-centered the way we want to be, then we have to actually tailor our care to that individual or that family if it's a pediatric case, for example. And so it really relates to what are the skills that we need to have in order to serve anyone, and it's about asking open-ended questions instead of closed-ended questions. And it's also about not being afraid of the answer that's coming on the other end, right? It's about spending time developing my own level of self-awareness, being more aware of my differences in my belief system, understanding my worldview, and trying to do my best to understand the worldview of others. It's accepting the fact that every interaction is a cross-cultural interaction, and that I cannot make assumptions about another person just because they are LGBT and I am LGBT, or just because they are African American and I am African American, right? And so simple tools like the Teach Back method, is something that we train on to help providers to be able to ask questions just to check to make sure that they've communicated in a way that the patient can understand, right? So how that relates to LGBT individuals, well, if I'm, serving someone who's part of the LGBT community and they prefer to use pronouns that make them feel comfortable, then as a provider, then I need to use the pronouns that makes that person feel comfortable instead of me trying to use the pronouns that I feel like will make me feel comfortable, right? Because a lot of the experiences that LGBT people have in healthcare that causes them to not necessarily trust healthcare institutions, it's not about what's happened in the past, it's more so about what's happening to me as I come, right? How included do I feel in this process? Am I being asked questions about my quality of life? Am I being asked questions about relationships? Am I being asked questions about, my health in terms of future planning or family planning? A lot of those questions get left off of the list when a patient discloses that they're LGBT, often because the provider maybe has some discomfort in asking the questions, or maybe they don't have a lot of training in knowing how to actually serve individuals that are a part of the LGBT community. Just to give you a few examples. If you want to know more, you'll take the course and you'll come to my training.
I don't want everyone to get a stiff neck, so I'm going to go over here. So there's just questions are overflowing. So Mary, I'm trying to not stack too many questions, but two things I was really curious from your perspective. One is, we have a lot of people in the audience who are kind of medical students or going to be residents, and they're probably coming in contact with their first transgender patients. What sort of recommendations do you have? Because this is a steep learning curve, right? It's not something people can kind of just walk into and know what to do and know how to. They may not have had much contact with the transgender community. Do you have any recommendations for them about kind of just how to feel comfortable in the situation, that sort of thing? And then my second question is, everyone's using everyone, and including us, are using LGBTQ, and transgender. There's some history why those groups are kind of clumped together, but it does seem like gender identity is very different, and a lot of the kind of leaders of LGBTQ are not transgender people, and so I'd like to hear your thoughts about that as well.
All right. Just advice for people who are starting to work with trans folks. Even if you don't think you're working with trans folks, you're working with trans folks. So you might not be able to tell that they're trans. They might not come out to you. You might think, oh, I work in an ER. Oh, I work on an L&D floor. You're working with trans people. So I guess that's step one. Step two is listen to them. How they talk about themselves is how you should talk about them. Ask what their name is, if their chart has their dead name on it, that's going to be the first strike against you. So a lot of trans people change their names. So if they've started in your practice or in that hospital before they transitioned, then they'll have the wrong name on their chart, they'll have the wrong gender on their chart. If they haven't, if they've socially transitioned but they haven't legally transitioned, which means changing their documents, those names might still, that name and that gender might still be wrong on their chart, even if they have completely socially transitioned. As a student, it's difficult to make changes to like the facility or the setting that you're working in. But ultimately, once you're not just a student and you're working somewhere, taking great pains to make sure that every aspect of their care experience is affirming to them is really important. So your front desk staff, your security, your EMR. Maddie Deutsch at the Center for Transgender Excellence at UCSF is doing a lot of research about and kind of like trying to write a training basically or a handbook about how to change electronic medical records to be more trans friendly. So it might seem like those aren't the important things, but those are many of the important things. How someone's addressed, how they're regarded, if they're respected, those are the key things. So having that be continuous from the moment they walk into the facility till the end of their visit is really important. And so you as a provider are just one piece of that, right? But you have more power in that setting than they do. So ensuring that they're receiving that respect from every person they're interacting with is important. So having competence trainings for the places that you're going to or for your classes and for your colleagues is really, really essential. But I mean, it's funny, I was talking to one of my colleagues about speaking on this panel, and she just sort of laughed, and she's like, I don't even know what I would say, because in my setting, we don't even think about it. But I mean, obviously we've done a lot of work to make sure that our setting is very friendly for trans and queer identified people, but it's just sort of written into our model that we're very respectful of people and that we listen to them and we respond to what they're saying and what they're asking for. So do that. Educate yourself. If you don't know something, that's okay. Tell them you don't know something. Don't make assumptions. Don't get curious. Only ask things that are relevant. I think those are good starting points.
Yeah, that's great.
Oh, you had a second question.
Yeah, so
It's kind of a big one.
yeah. Let me try and narrow it. Tell us from your. I mean, so do your clients or do your patients do they feel like they fit within the LGBTQ sort of label, or do they want to be separate from that? I mean, everyone has their own kind of ideas, but
Sure.
just like to hear you talk about it.
Yeah, I mean, I'd say I don't have a homogenous patient population, so it's hard to say how everybody identifies. We have a lot of people who ID as queer because they like the lack of genderedness of it as an orientation. It feels less limiting. So we also have a lot of non-binary and genderqueer people that we see, so I think that
Could you explain what
them.
non-binary?
Oh, yeah. Well, I'll try. So, genderqueer and non-binary people are included under what's called the trans umbrella. So, lots of people who aren't cis but don't necessarily identify as a trans woman or a trans man. So, the gender binary is the idea that there are only two genders, male and female. And so non-binary people don't feel that they're either gender or feel that they're both. And so there are lots of variations of that, like gender fluid or gender queer people who kind of reject the binary as the way that they have to live and present. So a lot of Q. And in my opinion, the T doesn't fit. It was too hard to get a freestanding trans movement, I think. And a lot of trans folks gravitated towards the gay liberation movement because they're similarly ostracized, you know. gay men are ostracized for their femininity, and so trans women, so too, you know, kind of link up. And a lot of trans women are straight, and so they identify with gay men because they're perceived as being masculine people who are attracted to men. So there are kind of a lot of rabbit holes you can go down when you start to think about how gender and sexuality intersect. But yeah, we never use the letters at my house center. We never use the LGBTQ letters. I think because we're just kind of, we consider ourselves a gender justice organization and a sexual health organization, and we don't care how you identify or what parts you have. So you love whoever you want as long as it's consensual.
Great. Yeah.
You got more for me? Really?
I'll give you a pass. I'll give you a pass. I'll give you a pass. No, that's good. Jim, so you talked a little bit about kind of dissemination of some of these newer prevention modalities like PrEP. Did you bring any flyers, or do you have any kind of ways, any new campaigns that you've been working on? And
It's such an obvious setup, isn't it? So yes, I just happen to have 5 slides I can show the campaign.
okay.
Should I do that?
Yeah,
Okay.
let me see.
So I'm glad you still saw part of our campaign. It was only supposed to be on the CTA for a month, but the CTA tends to be the gift that keeps on giving. You know, it kind of starts earlier sometimes, and then it hangs out until something replaces it. So we launched a campaign under the auspices of the Chicago PrEP Working Group, of which John is a member, with 160 other people. And we worked on this all last year. And in February, we launched the campaign, and it's called PrEP for Love. I'm going to show you just a couple quick pictures. So our tagline is one pill once a day, protect against HIV, so very simple. And we feature 4 couples. So we have a cisgender heterosexual couple. We have a couple with a trans woman. And we have 2 gay couples. And you'll notice they have words actually painted on their bodies. The idea there is that we used words that are associated with disease transmission, like spread, contract, transmit. And we paired those with positive, oh, it's going on its own. I didn't even do that. It's going on its, and we wanted to pair them to sort of have some tension and pair them with things that are positive around intimacy and love. The reasons why we have sex, for pleasure, for heat, for connection, to feel tingle. And here are some other iterations of that. We're using those those taglines, catch desire, transmit love, here as hashtags as part of our social media component of the campaign. Here's the other 2, so spread, tingle, and contract heat. And you know, we're focusing on Black people in our campaign because that's where HIV is the most acute in this city and pretty much everywhere else around the country. So we feel very strongly about representing them in the campaign. We did not hire professional models. They were all paid, but they were recruited from the community. So we did a community model call, and we not only looked at how they photographed, but we wanted to know if they were volunteers, if they were activists. We wanted to see their Facebook page, basically see how many friends they had, what their following was on Instagram, were they active on Twitter, and all those things were kind of looked at in a combination, and that's how people were chosen. And Bev here, the trans woman with heat on her thigh, she is a rock star on every social media scale you can imagine. And she's also absolutely gorgeous and lovely and vivacious. And she's really, really well known. So everyone who has seen her ads basically goes bananas in a good way. They're posting pictures of her campaign. They're taking pictures of her on the train and posting it and tagging it and going, you go, we're so proud of you. And so the value there is that she's well known. She's active in the community. People know her. And now they know about PrEP because of her, and it's a real person. So it's not just some nice face, it's someone that they actually have seen, and they will see, or they've seen in action. So that was our whole sort of MO for doing that. Here's our website. We are using all kinds of language that is very sex positive, so you'll see love is contractible, lust is transmittable, touch is contagious, catch feelings, not HIV. That kind of language goes throughout the site. It's very sex positive. We don't use words like risk and scary things. It's all sort of loving, embracing. We're very clear that PrEP does one thing: it protects against HIV. It does not protect against unplanned pregnancy or STDs. If those are things that are of concern to you, there are other things that you need to think about, condoms, etc. But we didn't want to overemphasize condoms. So condoms do not have a huge role in this campaign. There's a FAQ about condoms, but we did not pair condoms with our upfront messaging. And that was a very thought out choice. And finally, just what we're connecting to, and it's a great thing, we're connecting to something that has launched here at the University of Chicago. UC started a Chicago PrEP line a year, 2 years ago. So people can call and get information about PrEP, information about insurance navigation, healthcare, where to get it, how it works. And there wasn't a lot of, it's an unfunded, at the moment, sort of activity. So there wasn't a lot of promotion. There wasn't a lot of large-scale promotion. So we talked to John and said let's put your phone number on every single ad and every palm card and every poster. And so we did. And now the phone is ringing a little bit more. But it's a great thing, and it's a great service that now many more people know about. So you can learn about PrEP, you can read about it. Now you actually can talk to a human being, because that's what we want to do, is talk to a human being. We're not usually confident enough after we've read a FAQ. And then finally, we have Prep for Love live events. So it's not enough just to have a phone call with someone nice on the other line. We want to have events where people can kind of get together and hang out, maybe learn about PrEP, not even realize they're learning about PrEP, they're having so much fun. That's the goal. So we're doing these Prep for Love live events. We've done 2 so far in February and March. This one here features photos that were for one that was focused on gay black men on the South Side. And we did one just last week for women. It was called Formation, and it was inclusive of all women, so cisgender women and transgender women. We had probably 130 people there, and most of them were women, and people brought their kids, and it was great. And these are snapshots. We have a Prep for Love live photo booth, and they get to choose the tagline that they want, whether it's Catch Desire or Spread Tingle, and then they get a picture, and we give them a hard copy of the picture, and they get digital versions that they can then share across social media and help, again, spread the word from people that they know that we may not have contact with directly. And people love it. They love getting their picture taken. And we kind of hoped that would happen when we planned the campaign. We always talked about a photo booth thinking people would want to be a part of it, but we didn't know that. And indeed, they do. And this is a way for them to be a part. It was interesting when we first started rolling out this photo booth, and then I'll stop. People thought that they're like, oh, I'm in the campaign, so will I be on the CTA next week? Like, oh, you won't actually be on the CTA, but you'll get way more eyeballs on Facebook, trust me. If you have a lot of friends on Facebook and they have friends, I can't guarantee you'll be on the CTA, but they were really liking that. And that's it for my slides. So thanks for setting that up, John.
Thank you so much. Dr. Schneider has another commitment, so he's got to run. But I want to open for conversation and questions. Do you folks have questions for our panelists? Rita.
Okay, that's fair. Well, primarily gynae stuff. So we practice, part of our model is talk before touch. So before we touch somebody, we tell them we're going to touch them. We allow people to insert their own speculums if that's more comfortable for them. And it is what it is, but we let them look at their cervixes while the speculum is in. Or if they don't have cervixes, I have a lot of trans women who I offer the hand mirror too. So I don't know. I don't know. We're all patients too, right? Like, going to the doctor sucks. It's you don't feel respected most of the time. You don't feel listened to. You feel hustled through everything. You feel like a number. You feel like a paycheck. You feel like an insurance card. And so I have people's therapists refer them to me for their gynae care, refer them to me for their hormones, because they know that we're competent and they know that we specialize in those areas. And that we approach it from a totally different perspective than most places. We don't make a lot of money, so we're not trying to make money, and they know that. The ways that a lot of my my clients have been traumatized, a lot of them have been sexually assaulted. Almost all of them, I would say. Even my my folks who identify as male, and so a visit is a very intimate experience, even if you're not touching that person, right? You're asking a lot of questions about their identity. You're asking a lot of questions about their health history, their family's health history, if they've ever been pregnant, maybe they're a man. So that's, it gets complicated. And so if you don't approach that in a way that's sensitive, or if you ask a lot of questions out of curiosity because you've never met a person like that before, you've never thought about someone being that way before, or having that experience with that gender identity, then they're going to know that. And they're going to tell their friends. And no trans people will come to you. So I feel like it's just a matter of, like I said before, listening to them and taking their word for something. And trauma-informed care, I'd say, again, that's a whole different seminar, but don't pushing people around issues that you can sense they don't want to talk about, even if it's relevant to their care. The only time that I'll ever do that is if it's relevant to their safety. So I had a trans woman on, I don't know what day it was, Friday, who came out to her boyfriend, who she's been dating for a year, and he beat her up and dragged her out of his apartment by the hair. And she didn't tell anybody, and then she tried to commit suicide, which would have been successful, but her roommate found her. And so she ended up in like a sober living house, and everybody knew about her suicide attempt, but nobody knew why. And so I was talking to her, and she didn't want to tell me what happened. But I just kind of kept being like, do you feel unsafe? Are you still in touch with him? Like all that stuff. And, and so I asked her a lot of questions until she told me, basically. And I wasn't going for her telling me, but I was going to assess her safety. And, she has a lot of stuff around that, people who are trans or people who are not cis have a lot of stuff around their relationships. So if you're doing sexual health for people who have gender feels, it's challenging, because they have very, very difficult relationship histories much of the time, and might not want to talk about it with you if they feel like you're going to judge them. I really dig that you guys are being very sex positive around your prep stuff, because that's so essential. If you're not sex positive with anybody, I don't care if they're straight or cis or whatever, then they're not going to tell you the truth, Straight women aren't going to tell you they're having anal sex if they think that you're not going to listen to them or take them seriously or judge them. So it really, again, my colleague who was like, what are you even going to say about like how this is different? We can talk about disparities, and I'm sure that you can talk about disparities, which are very real and very important to healthcare, but I think it's also, you just treat them like people, right? And if that's too hard, then maybe you're in the wrong field. Does that answer your question? Yeah, for hormones, we don't see anyone under the age of 18. We'll see anybody else who has legs and comes in. But yeah, we refer people who are under 18 to Lurie's just because they have that very state-of-the-art, awesome gender identity wing or whatever it is now. So, yeah, and they're great providers over there, and we work really closely with them too. So, but otherwise, we seriously have people who have been coming to us for 40 years. We used to have a prenatal practice, and now we're taking care of the women who labored and were pregnant, for menopause, and their kids who are in their 20s. So it's pretty neat. It's a multi-generational thing. So, yeah. Yeah, yeah, absolutely. So I don't know if people are aware of this, but in Illinois, contraception and sexual health related stuff like gonorrhea and chlamydia treatment, all that stuff, you don't need parental notification or consent for those things. So yeah, a lot of people come to us for birth control or for general other stuff. Yeah, so send them my way.
Thank you. Before I take another question, I want to comment that our fellow, our incoming Lucent fellow for the coming year, her project is working on creating trauma-informed care, primary care. So we're really excited to have her working on that. Other questions?
So I'll start with answering that question. I had a few other things that I wanted to add to the conversation. But interdisciplinary care to me means that providers need to think on a more collectivist level and less on an individualist level, and think about keep in mind that patients are going through a whole continuum of care. They're not just coming in to see that one provider at one time. And so sometimes we may not feel we have a whole lot of time to spend with the patient, but thinking about the fact that we have multiple disciplines that are resources for us can help, and so that might mean making referrals to social work or to other departments or other disciplines to help sort of meet the needs of the patients that we're serving. Dr. Schneider had asked earlier a bit about why the T in the LGBTQ is included with the rest of the LGBT community, because it's really referencing gender and not so much sexual orientation. And one of the reasons, from my perspective, is that because there's not a lot of clarity and understanding about the differences between sexual orientation and gender, individuals are often discriminated against or stereotyped as all a part of the same group anyway, right? And so if I am transgender, I may be called names that are really related to someone's different sexual orientation, but that still is, me being targeted as a member of this group. And in terms of some of the things that LGBT people, as well as individuals who are HIV positive, experience when they come into medical care, just from the Lambda Legal National Survey, they've experienced things like being refused needed care, healthcare professionals refusing to touch them or using excessive precautions, healthcare professionals using harsh or abusive language, being blamed for their health status, or even healthcare professionals being physically rough or abusive. And 70% of transgender and gender nonconforming respondents had at least one or more of these experiences, where nearly 63% of those individuals living with HIV experience one or more of these same types of discrimination in care. Just to add a little bit to the conversation. Did either of you want to add anything to the question on thinking about it interdisciplinary and serving patients? Okay.
So at my health center, we have a counseling department. We also have an integrated health department. And so, not department, that makes it sound a lot bigger than it is. But we have acupuncture, Reiki, massage, and counseling all available under the same, in the same facility. And we have other kinds of body workers come through sometimes too. So we try to integrate different kinds of care, more holistic care, non-Western medicine. And I think that because of, traumatized folks will often associate all medicine with their trauma, and so if that's where it was perpetrated, and so sometimes those different modalities can be much more effective for them because they don't have the same associations with them. So that's how I see that. And as a nursing instructor, trying to be interdisciplinary in that setting, I'd say oftentimes, and I know this is going to sound funny, but oftentimes we forget about the patients, like as part of the interdisciplinary, especially when you're working with trans folks. They know more than you. They know way more than you about trans health than you could ever learn from a book or a seminar or from this panel. So respecting their knowledge and respecting them as the expert of their own experience is really, really vital to your interdisciplinary care, including them, not hiding information from them, not trying to hide your own ignorance. They'll see that. And so, just respecting them as people who have done a lot of research already or have been in the community long enough that they know a lot of the things that you're struggling to figure out from up to date, So I'd say that that's a vital part of the interdisciplinary care team that we don't really think about very often is the patient or their family, because they're a part of the team.
Great.
WPATH, the World Professional Association of Transgender Health, I think, is sort of like the established foremost guideline maker for trans hormone provision, and they borrow a lot from the Endocrine Society. I don't love WPATH because they come out of the tradition of the Harry Benjamin protocols, which, Harry Benjamin did a lot in his day, back in the day, to actually make trans medicine a thing, but he created all these hoops that trans people have to jump through in order to access care. So living as their gender identity, socially presenting as their gender identity for 2 years, having it verified by multiple psychologists and psychiatrists before, and then having to have certain types of surgeries in order to have their documents changed in order to live as the gender that they identify. And so that's a problem. Not everybody wants to do all that stuff. That's not appropriate for everyone. So, and it's also not patient-centered, right? Like, you're not trusting someone when they say, this is who I am. So WPATH is a good resource in terms of like the basics. The Center for Transgender Excellence that I mentioned before at UCSF, they actually used to be an HIV-centered place, and they've retained that research and then expanded it into the trans community, which is awesome. But they have a conference every 2 years in San Francisco or in Oakland. It was in Oakland last year. And they do Trans Hormone 101. They do all that good stuff. I learned how to prescribe hormones to trans women at Cook County Jail because there is a trans health project there, of all places. And so for trans women who self-identified when they were, I was going to say admitted, but when they're booked, they can access hormones if they were already on them on the street. And so that's where I learned. I kind of forced my way in because I wanted to work with that population. So that's how I did it. Hopefully, now, like, WPATH just had a training here through Advocate, like, in November. So trans medicine is really kind of picking up speed and getting a lot more attention. And we actually have research that's conducted in trans populations now. We're not borrowing research from postmenopausal women on estrogen. It's kind of rad. It's a good moment to get involved in trans medicine because there's a lot happening. More money and more attention is being paid. So, but I just say find a provider who's doing it and try to copy them. I'm more than happy to talk to anybody about the specifics of it. It's not hard. There's just a lot of monitoring. So I would hope, you shouldn't feel comfortable like you can prescribe hormones just from like listening to me talk right now. But don't turn someone away because you don't know how to prescribe hormones. It's not that difficult. You can figure it out. And that's half of medicine anyway, right? You're always having to figure stuff out when it walks in your door. So don't turn them away. Just call me. Just call somebody who does it, and we'll walk you through it. It's not hard, and that'll really change your relationship to the community.
Thank you. Andy, last question, and then we'll do some pictures and conversation.
That's a great question. Well, so it wasn't until very recently that I started seeing people who had access to surgery. Most of my population can't afford it. But now that, you know, ACA doesn't specifically address trans people, but it says you can't discriminate based on gender. So trans people are included in that, so they can get their hormones, they can have different kinds of surgery. So I'm seeing more people who are pursuing surgeries that are covered. I write the letters. I believe them. I feel like the research shows that it's very, very rare that people ever have any kind of regret about transitioning surgically. And it's imperfect, I think. Not everybody who doesn't want their penis wants a vagina, but that's what they get, So, and on and on and on, So it's imperfect. I think that actually, like talking about going from the margins to the center, I think the more that we do more intersex advocacy, the more we're going to be helping the trans community, because advocating for intersex kids who are having medically unnecessary surgeries on their genitalia, and saying like they don't need those, there doesn't have to be one kind of genitalia, there's not a binary for genitalia, is going to widen what it means to be trans and what's acceptable to be trans and how you can identify on documents and how you can identify, and not having to show your genitals to prove your gender. So, I think it is complicated. I totally hear where you're coming from. I think that, sending somebody for surgery with all those complications is really hard. And then, like, at what point do you draw the line between, like, this is affirming and this is cosmetic? I have a lot of trans women who get real into changing their face. And, do you. But I feel like you're running a lot of risks with that stuff. And that's not the stuff they need my approval for. They need my approval for the stuff they really need, So I write the letters. And then I just try to educate them and try to make sure they're connected to the resources that they need so they can talk through those decisions. Because I think oftentimes they're getting bombarded by the same sexist media that we are, right? Like, this is how I have to look to be female. And so hopefully if they can work out that stuff and we can advocate for them in the streets too, then those will stop being so concerning. Mm-hmm. Oh, sure. In the neighborhood. Yeah, give me your card. I'll forward you my resource referral list.
Good. On that note, people will be available to say hello, but we're going to do little photos too. Thank you so much to all of you for coming.